As we get started, Mr. Bothy, I'm going to start from the outside and work my way in, just like we did at your new patient exam. And I'm going to start back here and feel the soft tissues. And one of the things I like to do is feel these big glands back here by your ear. It's called a parotid gland. There's also a lot of lymph nodes in this area that we feel around. This is a little bit of oral cancer screening. Just checking. And we'll re-update this every 6 months to a year when you come back for your denture exam. There's some other big glands right up in here, submandibular gland, submaxillary up here in the front. Then I'll go back behind your head here and feel there's some little occipital lymph nodes. And the fact is, I never hardly ever feel anything, which is a good thing. Now I'm going to have you open real wide. One more time. And close. One more time. And close. Do you feel any tenderness on either side? No tenderness. That's because you've been wearing that denture on, mate. A lot of times what you'll find is a patient that has been wearing an old prosthetic device, an old denture, that's worn down and they've over-closed. In other words, their chin's too close to their nose. What will happen is that condyle, the mandibular condyle, will rotate and kind of over-rotate, and the lateral pole will rotate back into the retrodiscal tissue a little bit. And so those patients, by virtue of the fact that they're way overclosed, they'll have a little tenderness out on that lateral pole. What's interesting is, as I feel Mr. Bothy's joints, open real wide for me again, he's got a little bit of a catch on the right side. Not bad, but he deviates to the right just the tiniest bit when he opens. You feel that? Yeah. But he works around it. So I'd be willing to bet you that the lateral pole on the right side is slightly displaced. Wouldn't that be great to know before you start making a replacement, and that you're dealing with that and can notify a patient that, yep, we've got a little bit of a lateral pole thickening out there. Open real wide again. Doesn't hurt though, does it? And he's got a nice range of motion. His path of motion's a little bit off, but he's got a great range of motion. Now, I like to measure the range of motion in patients that have teeth with my fingers. My 3 fingers happen to be 40 millimeters wide. Now, I have big fingers. But you can use a ruler if you'd like. So Mr. Bothy's got a great range of motion. Close down about halfway for me. And what I want you to do is move your jaw to the right and to the left. Excellent. Excellent. He's got a good range of movement. I'm not going to do a lot of measurements and stuff like that because we're going to be doing a lot of that with our record-based and occlusion rims. I'm going to also get you to kick your head back just a little bit for me now. And would you just let your jaw hang? Just let it swing like a gate. The nice thing about a denture patient is if you leave their teeth out for a few minutes, you deprogram the muscles of mastication. And so I can hinge his jaw very, very freely. I've got my fingers right here in the notch, and I've got my bimanual manipulation. You can see the C. My little finger is back by the angle of the mandible. And Dennis, I'm going to have Mr. Bothy turn his head to the right, turn way to the right. And what I'd like for you to see is that hand position. You can see the C. I'm pushing down in the front, up in the back. And what that's doing for me is putting that condyle bone braced. Uppermost, midmost position. Now I'm going to get you to turn back. You'll also notice something else. My forearm is against Mr. Bothy's head. And I'm bracing my arm and his head so he can't move away from me. I can then snug up to him, and if I want to, I can lift up on his jaw, and I'm going to ask him this question. Do you feel any tenderness up by your ears? How about now? How about now? Oh, where my finger is. How about way up here by your ear? Right here. Now, I'll tell you, ladies and gentlemen, when you do that 3rd level of load test, that 3rd level, I'm lifting hard enough to pull Mr. Bothy out of this chair. I mean, I'm really lifting up. That's why I've got to have this arm here and my chest against him. And it's sore sometimes here.
Right there.
Right there. Yeah. And that's right where the maxillary artery comes right over the mandible right there, in that little notch. And so what you can do is take that third finger and lift it up, and lift down in the front, up in the back, and now it doesn't bother you as bad, does it? Yeah. And see, I've lightened my load there just a little bit. But I've got my little finger behind the condyle. So I'm lifting. You remember the old-timey can openers?
Surely.
That you had to go around like that? That's the movement, ladies and gentlemen. The old-timey can opener. You probably never used one, but in the Boy Scouts, we had one that was a little key that you went around the can with. And that's the movement you want to make, just like that. I feel real good about the fact that we could load test Mr. Bothy's both joints with total comfort. He doesn't have any palpable pain. He's got a great range of motion, and his path of motion is just a little bit off. Now here's what's interesting. The whole time I've been talking to you and talking to Mr. Bothy, Kathy's been back here documenting what I'm talking about. Now, Kathy's been through all the Dawson courses. She's been through Jack Turbefield's course 5 or 6 times. She's taken every CE course about I've ever taken. And so she has as much knowledge of temporomandibular joints as I do. And so as I speak, she writes it down and she documents it. We use the same forms that we use for people that have natural teeth. We can't do a tooth mobility check because there's no teeth in there. We can't do a periodontal exam because the periodontium is gone because there's no teeth. But we can certainly do a joint exam. So now what we're going to do is a little soft tissue exam. What I want to do is I just want to go around and look at the soft tissues inside your mouth because we've already palpated outside. What I do is I start by palpating the lips and the cheeks. And what I'm feeling for is any glandular tissue. There's a lot of glandular tissue in the lips and the cheeks. And then I'll pull the lips back and I'll take a look at the edentulous ridges. One of the things I'm looking for is any kind of osseous defects. I'm looking up here at the tissue in the front of the mouth, which would be the premaxilla, and see if there's bone under it or is it just flabby. I'm also looking down in the lower anterior to see the condition of the tissue. The tissue looks pretty good, Mr. Bothy. I got to be honest with you. Yeah. Very nice. I like to feel into the submandibular area, the retromylohyoid space. You know, the internal oblique ridge in a patient that's worn a denture for a long time can get really sharp. And when we make a denture that fits real well, that sharp internal oblique ridge, which is where the mylohyoid muscle attaches, and the mylohyoid muscle forms the floor of the mouth, it can be very uncomfortable to a patient. If they've got what I call a ridge runner, a denture that kind of fits like socks on a rooster, it won't be riding on that internal oblique ridge. But we're going to get a denture that fits so intimately that it will have a tendency to rub that ridge. The nice thing for Mr. Bothy is his internal oblique ridges are not sharp at all. They're nice and rounded over, which is excellent. The other thing I like to do, I'm going to have you stick your tongue out, and I'm going to grab a hold of his tongue, and I'm going to look under it. This is the best way to look under or look at a tongue. It pulls the whole floor of the mouth up so I can look back into that retromylohyoid space. And then you can also see how much mobility of the floor of the mouth there's going to be. And then lastly, I like for a patient to say, "Oh." And when I do that, I'm looking for a couple of things. Throat form. How big is the oral pharynx? How steep is the soft palate? I can get a lot of information there. But the other thing I'm looking to see is I'm looking at the posterior wall of the pharynx and making sure that we don't have any oral pharyngeal carcinoma or something like that. Your tissues look great. They do. We'll go through this once a year when we do our denture exam. You know, just because you don't have teeth doesn't mean you don't have to come once a year and let me look around. Okay?
This can count for this year, right?
This will count for this year, that's right. I think we have a good chance to be able to do some good things, Mr. Bothy. What I'd like to do, Jim, excuse me, is just put your dentures back in, okay? And then we're going to take a look at how they're in there. And what I'd like for you to do, Mr. Jim, is count from 1 to 10 for me real fast.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay? Very carefully now, one more time.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
I want you to take a look when he says 6, 7. And that S position, 66,
66,
77.
77.
And one of the best words is cells.
Cells.
That's 2 S's in a row, a C and an S. And so cells is one of those words we can look at. I'm going to have you turn this way just a little bit.
Just can't see the bottom teeth. Do you want to be able to see them?
No, you can't.
Okay.
That's one of the things we're going to talk about.
Okay.
And what I want you to take note of, come in as close as you can, Dennis, and I want you to count from 1 to 10 one more time, slowly.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now what I'm seeing is no teeth at all. You can't really see Mr. Bothy's teeth when he speaks. Turn this way for me now. Give me a big smile. Think of something dirty. Yeah. And what you can see is some teeth when he smiles. And so if we would assess a patient's dentures, just like we would a patient that we're going to put veneers on their teeth or do some sort of cosmetic or aesthetic procedure, I think we can look at it in the same regards. When he says 66, his lower front teeth come forward. And the fact that his upper denture has worn so severely in this area, when he says 66, these teeth actually come out past the upper teeth. So right off the bat, I know that Mr. Bothy, his lower jaw is going to move anterior and posterior when he says 66. The fact is, that also tells me his condyle is coming down out of the fossa, down the articular eminence, and so he's going to give me some posterior speaking space. So right off the bat, I can tell that we're going to have some posterior speaking space, and he's going to be kind of a classic class 2 or class 1.5, so to speak. Now what I'd like to do is I'm going to have Kathy put those retractor things in that we take pictures with and everything. We got a little floating going on in there. There we go. Now what I'd like for you to do is close down for me. There you go. And if you could hold that for me, I'm going to sit him up, Dennis, so that you can get a better look at that. And if you could, close all the way and hold it. Now, here's what's very interesting to me, and this is one of the reasons I'm so excited about showing you guys this case. Bite together again. When he closes, functionally, he's working as a class 3. The lower front teeth are in front of the upper front teeth. I just told you that I felt like he may be a typical class 1 or a typical class 2. But to get his teeth together, he's had so much wear over the years, his comfort position is class 3. So would it be legitimate to say I could take a class 3 all the way to a class 2? We're going to have to work all that out in our base plate and occlusion rim and when we're setting some teeth. Hold together again for me. He actually has a hard time holding his jaw that much closed.
Mm-hmm.
He starts to get uncomfortable. His masseter muscles are getting tight on him. And it's because he's over-closed. Now, did he lose vertical? You know, you've heard all this about you can't really lose vertical. Well, you can when you don't have teeth. With teeth and you have alveolar remodeling, you won't lose vertical. It'll come back. But with a denture, you can lose vertical by virtue of the fact that the denture wears down. So Mr. Bothy's comfort position and where he can eat is actually a class 3. At this point in our exam, we've done a soft tissue exam, we've done a little head and neck cancer exam, we've done a soft tissue and a joint exam, and so we would now take a photographic kind of essay of Mr. Bothy, and we'll share that with you with still shots in our presentation. The next thing we'll do, Kathy, you can go ahead and take those out of there. The next thing we're going to do is we want to be able to take some impressions of Mr. Bothy and start the process of making his new denture. There's one other thing that we would incorporate into our new patient exam, and that would be a radiograph, an x-ray. We'd want to take a panoramic x-ray of Jim's bones, basically, just to make sure that we don't have some sort of bony growth, tumor, cyst, or an unerupted tooth. So our radiographic survey is something that we do for our denture patients about every 5 years, just to make sure everything's okay. And it also gives us a really good idea of where the bone is. Why don't we get you to take your teeth back out again? I got, yeah, you got it. Kathy will take them for you.
Thank you.
And we want to go through the process of making some alginate impressions.